I'm Dr. David Rubin, and I'm from the University of Chicago, and joining me is Dr. Marla Dubinsky from the Icahn School of Medicine at Mount Sinai in New York. We are also the co-founders of a medical education organization called Cornerstones Health. We're coming to you from Digestive Diseases Week in Washington, D.C. This is an annual international meeting with updates in the field, and specifically in inflammatory bowel disease. Dr. Dubinsky and I organized a conference to highlight the best of this meeting for our professional colleagues, but we also recognize the importance of including patients in this, and we wanted to share with you some of the themes and updates from this meeting. I'm going to kick it off and start with something that's become very important in our field, which is the evolving goals of management for inflammatory bowel disease. We now have recognized the very important component of not only making sure our patients feel better from a symptom point of view, but also making sure that their disease is under better control. And that means making sure that there are objective measures that the inflammation's been turned off. So there were a number of studies at this meeting that have demonstrated not only that when people have that level of control of their inflammatory bowel disease, they do better, but also ways that we can measure that without always performing another colonoscopy or necessarily doing anything interventional. So that means is that we can use blood tests and stool markers and really know whether your disease is under better control. What did you see and what did you enjoy most about this meeting for our patients?
So I think it's one thing for us to think about the notion of treat to target, which I'm going to label what you just talked about, was the idea that we have a target that we've set. We, as a community, I think, and physicians have decided that the target we feel is actually if we can heal the intestinal lining, because we see that when you heal the lining, you have better outcomes. And so I think as we think about if that is our endpoint and that's our target, what are the therapies that are new that have been discussed at this meeting that may help us actually achieve those endpoints? So the one therapy that everyone was really excited about was tofacitinib, which is a JAK1/3 inhibitor, which was approved just May 30th, actually. And this was for ulcerative colitis, patients with moderate to severe disease activity, actually. And what they showed is that this therapy was approved for the induction of remission, which means after 8 weeks of therapy, the approved dose is actually 10 milligrams by mouth twice a day for 8 weeks. They actually also showed that in patients after 8 weeks of therapy who weren't quite reaching the endpoint of remission, for example, that they are able to take another 8 weeks of treatment. But in addition to that short-term goal, we also know that this drug is effective for long-term, which means the data shows that at a year, patients were able to maintain remission, not just maintain remission, maintain a steroid-free remission from 6 months to 12 months.
And heal their bowel in many cases.
And heal their bowel. So that fits with that treat the target phenomena, because if we're not going to have drugs that are able to meet the target, it makes it difficult for us to communicate treating to target or that concept.
So we add this new drug, tofacitinib, to the list of other therapies that we thankfully now have for both Crohn's disease and ulcerative colitis. And thinking about how we can use these therapies the best way possible has been a really important theme of a lot of our recent meetings.
Yeah, in addition, what I think it lends itself to is as well this meeting is to think about the future of therapies. I think the idea is that we're now starting to understand different mechanisms or different classes of therapies, we call it. So for example, there are other JAK kinase inhibitors that will be available hopefully in the not too distant future. We saw the data from 2 other products, and just as a reminder, tofacitinib is a JAK1/3 sort of terminology, which isn't necessarily what needs to be remembered as much as the fact that future therapies will be variants of or next generations. So there'll be kind of different combinations of blocking these types of pathways. So we saw that those are promising. We also showed that other mechanisms that will be coming out, hopefully in the not too distant future, for ulcerative colitis as well. We saw the data of a new class of therapies called the P19 blockade or IL-23 blockade. That's very exciting that there'll be that class that we'll have in the future as well. We hope that all these therapies kind of as they go into what we call phase 3. As a reminder, phase 2 is the sort of intermediate phase, we'll call that, and as we head into the phase 3 information, further meetings, we'll be able to update the patients on that as well.
So for patients out there, the message really becomes that if you're feeling well, that's great, but you also want to make sure that your disease is under good control, which means going the next step and having a conversation with your physician or your advanced practice provider to make sure that there are markers that your labs have normalized and other ways to know the disease is under control. And if you're scratching your head and wondering, all these new therapies, how can I possibly know which one is for me? Why don't you explain some of the ways that we're figuring out how to do that?
Yeah, so this idea of precision medicine, shall we say, or precision IBD, there's kind of different ways we go about it. The first way, which was shown also at the meeting, was discussing the role of maybe using decision support tools and decision aids, where we have things that are available, for example, virtually, be it on the web or on a phone application, where people are able to kind of put in their own individual information and be able to see. We'll start with prognosis, which means the trajectory or their natural history of their disease. And we know that when patients feel informed about their own individual natural history, less so about what other people's natural history have sort of taken or what they've heard about a certain therapy, they start to realize that the drugs need to be individualized themselves. Not just how they feel today, but also are there various factors that me as a patient would have that sets me apart, that I should be having a deeper conversation with my physician saying, all right, I may feel okay right now, I may even look okay right now, but are there factors that I have as a patient or a patient would have that says, in the future, I may be at risk of surgery? So being able to have sort of what we call real-time display or decision support, that tool that actually helps me and my physician communicate my risk and me understand why that drug is better for me, is really interesting. Other things in the future, and hopefully it's not too far away, would be actually using new technologies and new platforms where we can actually go to the tissue at the time of colonoscopy, put it together with these novel testing strategies and platforms, and it says, me, I would need drug A because I make inflammatory protein A, for example,
Sure.
U, B, and et cetera.
And one of the big challenges has always been that drug A may work for a while and then it doesn't work later. So we're getting better at predicting who might lose response.
Sure, yes.
And in some future analysis where we might have some kind of panel of inflammation markers, we could actually predict that you're going to lose response to drug A after it's been working for a while, and now it's time to go to drug B. So we're working really hard to finally have a better idea which treatments to use. And with all these new options, it's necessary because we don't want to just keep going through one drug after another, waiting for something to finally work. We'd really like to do a better job at not only predicting that the drug would work, but keeping people on them.
Yeah, I think we talk about this concept of right drug for the right patient, at the right dose, at the right time, and this continuum of precision. One thing you noted that maybe there will be genetic panels or some kind of biomarker panel that says that a patient would respond to this drug initially but may lose response. There was also some gene panels that were presented that may describe patients who may be at risk of developing even antibodies or intolerance to our more common therapy, for example, anti-TNF therapy. And I think when you talk about precision medicine, it's hard to not talk about precision health in a sense that there are really good studies that have shown that you can measure how much drug you have in the individual patient, meaning by measuring it in the blood at the time, for example, right before an infusion. We can maybe take the drug dose that is measured in the blood and say, this is the concentration or the level of the drug. And we know that there are certain levels where you have a better chance of being a responder. So maybe that's that right dose situation that we talk about. And I think being aware that there are tools that have been around that can help us be better dosing our patients, because historically a lot of patients would start on a therapy and then over time lose response.
Right.
And we begin to understand that it may not be about the fact that it's something wrong with my disease, but maybe it's the way your body is clearing these drugs. And that's what differentiates, I think, a biologic from a small molecule or some of these newer pills that are being introduced, like tofacitinib.
Yeah. Well, so in addition to understanding a little bit more about how the drugs are working and when they might be losing response, we also have learned a lot more about how to monitor the disease. So we can actually pick up inflammation now before the patient knows they have it, before they're feeling symptoms, and that enables us to address that, we hope, by adjusting therapy before they end up sick, before they have a complication. And that type of monitoring using something called fecal calprotectin or even a blood marker called CRP has become really much more accepted and much better studied in our field. So for the patients out there, we want them to know a little bit more about these markers and how their disease can be measured, as well as understanding how to choose therapies and have meaningful conversations with their doctors. Now, the other theme that was of interest to us has been the ongoing discussion, and a very important one, about psychosocial issues and psychological health around inflammatory bowel disease. We certainly have known for a long time that patients who have Crohn's disease and ulcerative colitis have a higher risk for anxiety and depression, and we've also known the value of having professionals who can work with us to take care of them. But one of the challenges has also been identifying those patients who are at most risk and having enough resources to engage other psychological professionals to help us with those people. So there's some newer tools to help people get screened, and even online and interactive resources that will help people get treated for some of these problems. And we really want to emphasize the importance of including that in the care for IBD patients.
Yeah, I mean, I think we'd be missing a large part of the story. Behavioral health is such a big part of how we manage IBD, and unfortunately not everyone has access to a full service center where there is a psychologist or a social worker who can screen individuals, determine they're at risk of having anxiety or depression. I sort of come from this philosophy that maybe anxiety and depression is what we want to prevent. Are there ways, just like you mentioned being proactive with everything else in the IBD space, why can't we be proactive early? Why can't we determine which patients, even as early as the waiting room, somehow there's a screen that then lets the team know that this patient may require referral out if you don't have those services, or maybe these online meditation, self-regulation programs.
So let the patient know too.
And let the patient know that these services are available.
So the other major theme that's emerging is one that patients always ask us about, which is understanding more about how diet influences their disease and whether or not we can use diet to treat it. So at this year's meeting, there were a couple of interesting studies that started to show us that exposure to sugar, some processed foods, might be related to earlier recurrence after surgery, and it's part of a much bigger and complicated picture, but it certainly supports what we've all been trying to figure out, at least at the preliminary stages. So this is evolving, but we remain very interested in knowing a little bit more about diet, encouraging healthy nutritional intake, and trying to educate patients about things that don't work, like eliminating all the foods or becoming malnourished in the process of trying to starve out the disease, which really has not worked the way we'd like it to.
So I'd like to add that, yes, there are certain foods we know that maybe increase the impact on the microbiome, which we know is a definitive part of IBD. The question is, as you noted, what are these specific foods? Probably by eliminating all foods that bother you, you will end up being malnourished, and that's maybe even a bigger problem. Right. So I think talking to the physician or asking them to refer you out, similarly, to speak to someone who's familiar with which foods may impact symptoms. I think what I just said, I think I want to really make a point, is that just because someone has symptoms, for example, change in stool frequency, increasing bloating, some cramping, it doesn't always equal flare.
Right.
And we know that there are certain foods that could make you bloated, make you run to the restroom faster, may make constipation as well. So I think part of it is understanding what are foods that are actually impacting the biology, the actual inflammation characteristic of IBD, versus foods that are just kind of aggravating symptoms. Because some of those are easier to fix than others. Yes. And that's why I think what we're beginning to realize is that there are other factors other than actual inflammation found. Going back to your original thought, you need to look to see why someone is still having symptoms. You may have a fecal calprotectin that's normal, you may have a lab that's normal, patient's very symptomatic, you actually undergo a colonoscopy, nothing to be found, and yet we forget about the impact of stress, anxiety, and diet on the GI tract, and we miss that part of the story often.
Well, so we started with talking about how we want patients who are feeling well to make sure their disease is under better control objectively so that they're going to do better longer. And we're ending by reminding them that not all symptoms are related to active inflammation. So this is the whole issue of understanding what inflammation is, measuring it in effective ways, and then introducing all of these different treatment options and some of the newer therapies that really are changing the natural history of the disease. So it's a very promising time for patients with inflammatory bowel disease. This was an exciting meeting. There were over 1,000 studies just in inflammatory bowel disease presented here in the last 4 days, and we're working really hard to make more advances in the field. If you'd like to learn more, please go to our website, cornerstoneshealth.org, and of course talk to your physician teams, and we really encourage you to get involved. The engaged patients do better.
Thank you so much for your time and for listening.
Thank you very much for joining us.